So we are operating virtually again this year, and we are so happy to have VCU Massey Cancer Center with us today, sponsoring the Health Forum. We're going to get so much good information from that. So we're happy everybody's here, and we are going to start with our opening prayer. Our prayer, it will be brought to us by a beloved member of our advisory board, Dr. Alice Freeman. She is involved in healthiness, body, mind, and spirit. She has a ME in Christian education, and she is also very, and she'll tell you a little bit about herself if she wants when she comes on, but she is very involved in lactation training, all sorts of health types of things, and we love her so much. So Dr. Alice, if you would open in prayer for us, please.
Thank you. Let us pray. Lord, we take delight in this day that you have made. Our hearts rejoice, and we are glad in it. We are centered in this space virtually, but you know why, and you know what you're doing, and we're thankful. We are grateful that we get to worship you in the beauty of your holiness as we collectively come together to create the synergy for the change through our Sisters Network Central Virginia yearly walk. We ask, Lord God, that you help us to remember those who have gone before us, that are now our cloud of witnesses, cheering us on as we allow goodness and mercy to follow us, continuing our good fight of faith. We ask, Lord God, that you will strengthen us out of your glorious powers so that we can see you at work in everything. We thank you for medicine. We thank you for science, but of all, we thank you for you, divinity, that's implemented in every aspect of our lives. We give this event to you. Make your presence known as we lift you up today for all the world to see. It is in Jesus' name I pray, and for his precious sake, amen. Thank you, God.
Amen.
Thank you, God. Amen. Thank you, God.
Beautiful.
Thank you, God.
All right, our next person, as we all know, music is healing. So we always try to have a song for this event. I asked this young lady to send me a blurb to introduce her. And she said, just say, I'm your daughter, blah, blah, blah. So this young lady is very, very talented. She's graced the Broadway stage. She is all over the place, performing everywhere. She was my birthday gift on my 23rd birthday. So next week we will celebrate our birthday on the same day. We'll still be 23 years apart. We don't need to tell any of that other stuff. So Crystal, if you would come now.
Unmute.
Oh, there we go. I was about to do the whole thing muted. Good morning, everybody. I'm so happy to be here with you. And I'm just going to sing a little song about walking together through whatever storms come. Here we go. When you walk through a storm, hold your head up high and don't be afraid of the dark. At the end of the storm, there's a golden sky and the sweet silver song of the lark. Walk on through the wind, walk on through the rain, though your dreams be tossed and blown. Walk on with hope in your heart, and you'll never walk alone. when you walk through a storm, hold your head up high and don't be afraid of the dark. At the end of the storm, there's a golden sky and the sweet silver song of the lark. Walk on through the wind, walk on through the rain, though your dreams be tossed and blown. Walk on with hope in your heart, and you'll never walk alone. You'll never walk alone. You'll never walk alone.
Ashe, ashe, ashe. Oh, wow. Beautiful.
Oh,
Beautiful.
you bring me to tears every time you sing, girl. You bring me to tears.
Beautiful.
Thank you so much. Thank you for having me.
Oh,
Okay.
Crystal.
All right. Let me get it together. All
Yeah.
right. It's my pleasure at this point to introduce our MC for this morning, Reba Hollingsworth, news anchor with WTBR TV 6. Now, if anybody is in Richmond or around Richmond, you know this lady. She's a longtime supporter of Sisters Network Central Virginia. She reports and produces a monthly Buddy Check segment, which raises breast cancer awareness and encourages women to have monthly breast exams. So how could we not partner when our goals are so closely aligned? So please help me welcome Reba Hollingsworth. Thank you,
Hi,
Reba.
everybody. Good morning. So I have to follow Crystal. You're amazing, Crystal. Beautiful voice. Thank you, everybody, for being here. And it's just an honor and a privilege just to be here this morning. It almost feels like a reunion because I see so many familiar faces, but it is a privilege to tell the stories of breast cancer survivors and those stories through the eyes of the doctors who are on the front line with our Buddy Check 6 reports. We have such a dynamic group of panelists today here this morning to just give us just this wealth of information and to answer questions. And I've had the pleasure of interviewing many of them who I see here this morning. Before we meet our distinguished panelists, I'm honored to introduce the moderator this morning. Dr. Debbie Cadet is the program manager for community health education and research at VCU Massey Cancer Center. She oversees Massey's research and resource centers in Danville and Lawrenceville, Virginia, as well as activities of Massey's NCI National Outreach Network community. Dr. Cadet has over 25 years of experience as a clinical social worker at Virginia Commonwealth University and spent over 10 years working in the Dalton Oncology Clinic counseling cancer patients and their families. She has served as a consultant and taught psychosocial care for patients and their families to nurses, medical students, residents, fellows, and attending physicians. And she enjoys working in the community to positively impact the lives of citizens. Dr. Debbie Cadet, good morning.
Good morning, everyone. You all are in for such a treat. We thank you all so much for being here with us. Thank you, Reba.
Thank you.
So I guess our next speaker would be Dr. Shepard. Are you before Dr. Hackney or Dr. Winn? I thought Debbie was going to introduce the next speaker, but.
Well, Dr. Mary Helen Hackney is an attending physician at VCU Medical Center, and she is ready to give us all of the information that she has a wealth of work in the community. We also have a video of Dr. Robert A. Winn, and then we have Dr. Sheppard, who's going to round us out. So let's go ahead and start with Dr. Winn's recording, and he'll be joining us later on. And Dr. Robert Winn is our Massey Cancer Center director. Melissa, do you have the video? In the meantime, we're happy to go on to Dr. Mary Helen Hackney, a longstanding attending physician in the community. Breast cancer is near and dear to her heart as well. And she will present to you the work that she's been doing and the information that she's an expert in.
Okay, can everybody see the slideshow?
Yes.
Yes.
Okay, and can everybody hear
Put
me?
it in
Okay.
presentation view.
Pardon?
If you put it in presentation view.
Okay, let me go back up here. Okay. Sorry. That's what happens when, okay. Trying to move it down so I can I need to get rid of this piece. Okay, stop video, chat.
Is it the little, looks like a TV with the arrow in it? Will that put it in presentation view? Is that what she needs to do? I think at the top there. The little one with the arrow in the middle. I think that'll put you in presentation.
Let's see here.
Yes.
Okay, what did I just do? Let me get rid of that.
Click on slideshow.
Yeah, that's what I'm trying to get to here. So, actually, let me do this. Let me leave that. There we go. No, I don't want to do that. Ooh, almost got myself out of the webinar. That's not what we want.
You can't get up to slideshow. File,
I can't get up to it right now. I've got
Come
this
over,
pen.
come over to
Oh,
your
wait a
right.
second. There we go. There we go.
Come over. There you go.
There we go. Let's go from the beginning here. We can always get technology to work eventually here.
There we go.
Okay, so many of you have heard me talk, and you know I will talk, but I've been told to make this relatively short, and I'll do my best. But we're going to talk about surviving and thriving after breast cancer. That's not my creative title. Somebody else has come up with that. And so, okay, let's see. There we go. And the reason, we've got to think about breast cancer, there are 281,000 women got diagnosed this past year, or they're estimated for this year. So that's a lot of women getting diagnosed, but it is not the biggest cancer killer of women. We still have to remember that lung cancer is the biggest cancer killing of women. So no smoking, anybody. I'm saying that for Dr. Winn's sake, because I know he's going to say something about that. The other thing we have to remember is that breast cancer is a cancer of getting older. Although we do see younger women getting breast cancer, and in the African American women, it tends to be younger, but it is still basically a cancer of being older. So the biggest group who get it are between ages 50 and 70. So, you think going like, oh my gosh, when do we get it? So those are the time frames. What we have to think about is also who's a survivor these days. And, they used to say, well, okay, all these women are getting it, but we have less than 40,000 women dying a year of breast cancer, which is great. Fewer deaths are better. So, then we go, well, what's a survivor? So a survivor can be 5 years from diagnosis. That's the old term. You had to be 5 years out, then you're a cancer survivor. Nowadays, we call a survivor the minute you get diagnosed and you start fighting your cancer, you become a survivor. And that's really critical because you want to be on the forefront of your health. And this fits with Commission on Cancer and a lot of other groups that are defining survivorship. The other thing that's fairly new, and that's come out really in the past couple of years, is survivorship after recurrence of cancer. Because we know that with all these new therapies out there, people aren't dying immediately after a cancer recurrence. And we have cancer survivors, including breast cancer survivors, who may be 10 years out, still fighting their disease in some capacity, but they are surviving and they're still thriving. And this is a good slide to sort of really emphasize how many people are going to be surviving from breast cancer or from cancer in general. that if we look at 2021, there's somewhere like 17, 18 million cancer survivors out there these days. 2.8 million of them are breast cancer. So we have a lot of people living a long time. To that effect, though, we have to remember that some groups are not getting as much benefit as other groups are. African-American women have a higher mortality from breast cancer than other groups. You're more likely to get breast cancer at earlier ages. The median age in Caucasian women is 62. That means half women are over 62, half are under 62. African-American populations, it's more around 60, maybe as low as 58. So slightly younger. African-American women are more likely to get triple negative breast cancer, which is a very aggressive type of breast cancer. How do we change this? We advocate for early detection. We advocate participation in clinical trials. We make sure people get treatment. We support each other as they're having a diagnosis to know you can get through this. And if you need to, you get another opinion. So I have to have this slide for Debbie and Dr. Sheppard, Dr. Cadet, Dr. Winn. How do we make a change? And that's going to be clinical trials. And I know Dr. Winn's going to say more about it. But remember that trials are not just for a last resort. They are at all levels of care. And they're very rigorous now. They're evaluated at multiple levels for scientific value, ethics, purpose. So there is a continual checks and balance system going on. We don't want to replicate anything of the past. But just to give you an idea of how diverse trials are at Massey Cancer Center, we have a trial called Henrietta. They tend to give funny cute names to trials. Henrietta. It's a new approach to radiation therapy where people may be able to get less radiation than the traditional 6 weeks after breast cancer. We recently closed a trial called Upbeat, which was looking at cardiac function and fatigue during chemotherapy in the first few years after treatment. So looking at that survivor. We have an active trial right now called Comet, where people with stage 0 breast cancer may be able to avoid surgery and just be on a hormonal therapy. We have a trial called Compass. Maybe we can tailor the chemotherapy down a little bit for a particular cancer. Dr. Sheppard can tell you about some of her trials looking at hormonal therapy and compliance and side effect management. And we recently closed a trial called the Be Well trial, accrued nationally, looking at weight loss after treatment. Again, we're looking at that survivor. So let's talk about what we go next. Let's talk about being the survivor. You've had a mammogram, you've had a biopsy, you've had surgery, you probably have had chemotherapy, maybe hormonal therapy, maybe radiation therapy. So what next? So everybody would love that magic thing that says you never have to worry again, but unfortunately it's not there yet. So the recommendations right now, this comes from the American Cancer Society and ASCO, our national organization, is that you need to continue follow-up after your treatment. It sort of kind of makes sense. But basically, you need to see one of your cancer-affiliated doctors every 3 months. Some people do it 6 months if it's early stage cancer. Every 3 months or so for those first couple of years. Then every 6 months till you hit about year 5. And then you're going to be seeing somebody every year. Now, if you are on hormonal-based therapy, you might continue to see somebody every 6 months, but you need to be evaluated. And what are we going to do? We're going to ask you a bunch of questions. Any lumps, bumps, losing weight, aches, pains, something that makes us worried about what's going on. And so we're going to see in the next slide about what testing we do and what we don't do. If you still have a bosom, if you still have a breast, then you're going to be getting a mammogram. And your mammogram is going to be at either a 6-month interval, but more likely once a year. Breast cancer rarely develops very quickly overnight. So the still standard is mammography once a year. And we're going to talk a little bit more about mammograms. If most women do not need breast MRIs, there's only a select group of people with very dense breast or a strong family history who need a yearly breast MRI, but most people just need that mammogram. And that is still by far one of the best tests out there. Now, what everybody always asks me is prove I don't have breast cancer. I wish I could. And they want a blood test or something that can give some confirmation and peace of mind. There are some companies that are looking at blood samples to see if they can find either circulating tumor cells or circulating DNA that says, yes, you have breast cancer, but it's not ready yet. It's certainly not working well for most breast cancers. It seems to be working a little better for colon cancer. People are thinking about it. We just don't have that good marker out there for breast cancer. So there's really not a regular test that we do. Things we incorporate as part of good health, making sure your cholesterol is okay. That can be with your primary care doctor, making sure your vitamin D levels are good. Again, that can be with your primary care doctor. So there's no cancer specific blood work here. And the key is, if you start to worry about something, is that you come in and be seen. You raise your hand and say, Doc, I need to have a talk with you. One of the other things we're increasingly encouraging is genetic counseling. And even though less than 10 women out of 100 have a genetic abnormality that we can find right now, we do encourage that you share family history, not just for breast cancer, but breast cancer, ovarian cancer, pancreatic cancer, colon cancer, prostate cancer, because sometimes these cancers are seen in family groups, and it may give us information that says other members of your family need to be screened sooner. And so we do recommend genetic counseling, and then from that, we do genetic testing. So it's good to understand what the genetics are, and from then we can go to counseling. And everybody always asks us, is this going to lead to discrimination against insurance and such? There was a law that was passed some years ago, and it is not supposed to lead to any insurance discrimination. Again, a word about breast imaging. If you still have a breast, the ones you were born with, then you get a yearly mammogram. And more we're doing something called 3D mammogram or tomosynthesis. It's the same pull and squash, but it gives a better view looking through dense breasts or breasts that have had scar tissue. They're working on trying to get rid of the extra costs that sometimes this will incur, but it gives us a lot better imaging. Again, as I said earlier, MRI only for a limited number of people. Not everybody needs to get an MRI every year. Talk it over with your provider. An ultrasound may feel easier, but it's not as good. It's mostly useful for non-cancer lumps and bumps in 20-something-year-olds. Now, if you've had rebuilds, you're reconstructed, you've got implant reconstructions or flap reconstructions, those do not need routine imaging. Now, there's no mammogram on a flap because there's no breast tissue. 95% of it's gone. And this is a little bit of change over years ago. People used to still try to mammogram flaps. If you have implants, the discussion is, are the implants in good enough shape? Have they exploded or deflated? The company that makes the implants says, oh, you should image them every 3 to 5 years just to make sure they're okay. But that's a lot of expense and discomfort. If they look good, they're good. There's a mixed view on that, but no mammograms for flaps or for implants. And, don't forget your mammogram. We've had a lot of people delay it due to COVID, and mammogram suites can be really cleaned up well. So don't forget your mammogram. And I'm talking as somebody who needs to get mine scheduled here. But 2 minutes of discomfort on each side, save your life. It's a bargain. It is still by far the best test for impacting survival from breast cancer. So part of Buddy Check 6 that Reba works with is not only know what your body feels like and look for lumps and bumps, but make sure you get your mammogram. If you find a lump and the mammogram is negative, or you find a lump and somebody poo-poos it, says, don't worry about it, go get it checked out. Okay, it's your body, it's your life. Make sure you get the information you need. So I have a whole hour plus talk about survivorship. We're not going to talk about everything there, but this is, I'm going to hit a few highlights I want people to think about right now. But this just gives you an idea about some of the things we have to think about for cancer survivors and breast cancer survivors. And there is research going on in all of these things. And if somebody, you've had chemotherapy and your brain's not working as well as it used to, there is a reason there. And we do have some people who are working on that, trying to improve that for people. Fertility, sexuality, it's now mandated or trying to be mandated that we must talk about fertility with every young woman before we start chemotherapy on them. So I thought I'd hit a few highlights of people who are thinking about, what am I worried about? Lymphedema always is a big worry. Lymphedema is basically swelling of the arm after having had breast surgery on that side. We don't see as much of it as we used to. Newer surgical techniques are critical for helping doing that. We don't remove lots of lymph nodes anymore. Now we remove 1 or 2. They used to remove 10 to 20 lymph nodes. So the biggest risk of getting lymphedema is high number of lymph nodes removed, being overweight, having an infection after surgery, and having radiation. So the actual risk of swelling of that arm is only about 15% over a lifetime. Lymphedema can happen at any time, but now it can be as low as 4% with our newer surgical techniques. Some women, if they have a lot of lymph nodes or radiation, it can be as high as 25%. So if your arm starts to feel heavy or it actually looks swollen, if you measure it, it's more than 2 centimeter difference, then get it checked out with an appropriate physical therapist or occupational therapist. We've also gotten away a little bit from the no blood pressure, no venipuncture, no blood sticks in the arm that had surgery. If you need to have it done on that arm, do it. But the key is you just don't want a tourniquet there forever and ever. So have them, tell them, be ready, stick me, then let's get that tourniquet off. But if that's the only place you can safely get your lab work, get it done. And there's actually now a surgery where if you develop bad lymphedema, they can actually transplant some lymph nodes and other vessels to try to help drain that. It's only done in a few sites. The physician here in Richmond who was doing it moved to California. I think the nearest place is North Carolina. I'm not sure if there's anybody at Hopkins right now doing it, but so there is now a surgical management for lymphedema. As I said, we're talking about survivors here, so we're not going to talk about all the treatments and stuff. But just remember, if you get a segmental mastectomy and radiation therapy, the treated breast is going to shrink a little bit, oftentimes, maybe a little perkier. If you gain a bunch of weight, the treated breast is not going to gain weight. So if things look lopsided, then get a prescription for specialty bras and inserts so that you can feel good and look good. If you get a mastectomy, you don't get rebuilt, again, get a bra and prosthesis that fit well. And most insurances will help cover this. And you need a prescription. It can be from any of your physicians, doesn't have to be an oncologist. There are specialty stores that do fitting and can help get the appropriate equipment or prosthesis and bras. There's the TLC catalog from American Cancer Society. It's got a load of things. And you can get usually 3 to 6 bras a year and a prosthesis every other year, or inserts if you just need to even things out. And if you're athletic, like everybody's going to be walking today, you can get specialty prosthesis for athletics that are good for swimming and water aerobics, those type of things. Women, one of the other things that's required from Commission on Cancer is that we talk to women about breast reconstruction. And ideally you do it before the time, at the time of diagnosis, so that when you plan your original surgery, you're thinking about, do I do a lumpectomy and radiation? Do I take the whole breast off? Do I need to do reconstruction? So you think about it early on, and we will think about reconstruction for pretty much for anybody under age 75 or so. It depends on how well you are. You want an appropriate weight. You don't want to smoke because that will make a reconstruction not work well. but there are many opportunities out now for reconstruction, whether it's using your own tissue or an implant. So don't be afraid to ask about it, because you want to feel good. You want to feel like your body is yours and you can put your clothes on and go out, and the rest of the world's not looking at you cross-eyed going, is she unbalanced or not? You want to feel good. And there are a lot of opportunities for nipples now, tattoos, rub-ons, silicone replacements that glue on. Who knew that all these opportunities are out there? But reconstruction is something you have to think about. Breast exam is still part of your care. They've gotten a little bit away from doing the monthly exam, but it still makes good sense because you got to know what your body feels like. Mastectomies remove a bunch of 95% of your breast tissue. So you're still going to feel along the breast mounds looking for anything that feels like a hard rubber eraser or a lump. It's rare that we see additional cancers after breast cancer, thankfully. But we do have to remember that that happens on rare occasions. So we're going to end with a couple of slides on lifestyle here, because we want to be fit. Are we all going to walk today? We want to have good nutrition. We've got great attitude. We just started with that song and prayer, so we know our attitude is all set. And then we want to be working with our healthcare professionals for focusing on wellness. We know obesity increases the risk of recurrent breast cancer, and it's particularly important as a risk factor in women after 50, 55 years of age. Also increases the risk of endometrial cancer. We know that poor blood sugar control may also increase the risk of cancer by being an inflammatory agent. And so when everybody says don't eat sugar, it's not that sugar itself is so bad as it is the extra weight, the blood sugar out of control that it creates this inflammation in your body. So those are the key factors that we have to worry about. So we want to look at obesity. We want to look at reducing obesity. It increases our lymphedema. So there's many studies out there that shows that we can reduce cancer mortality by getting our weight under control. And in breast cancer, we've been doing clinical trials to that effect. There's no magic anti-cancer diet. I wish there was, then everybody could do it and I could be out of a job, or I could be doing something different. But the main thing you want is a good diet, fruits, vegetables, grains, low fat, healthy proteins. There's no magic supplements. People will sell you hundreds of dollars worth of supplements. Maybe some vitamin D for bone health, but if you eat a big green salad with all kinds of stuff on it, that's got all your vitamins in it. You don't want to drink alcohol too much. Women have more toxicity from alcohol. So for women, it's a glass or less a day. If you're ultra conservative, no more than 3 glasses a week. Some people will say up to 7 glasses a week, but for women, reduce alcohol consumption. And soy products are safe. Everybody gets gung-ho that it's going to look like estrogen, but they actually are very safe, and they're a great form of healthy protein. We want to get people moving. We know that physical activity makes a difference. It keeps your blood sugar under control, makes you sleep better, helps your diabetes, helps blood pressure, helps the stiffness that you get from your hormonal therapy. So you want to move. The recommendation right now, 30 minutes a day, 30 minutes a day. You can lump it up and it can be broken up. It can be 15 minutes in the morning, 15 minutes at night. You want to move, and we know physical activity makes a difference. Don't forget about your other cancers. You got to get your colon cancer, your colonoscopy done. If you have been a smoker or are currently a smoker, lung cancer screening. Dr. Winn just got a massive grant to work on lung cancer activities at Massey. Cervical cancer screening. If you still have your parts, i.e. your uterus and your cervix, you need to have a pap smear. And it's the guidelines vary on your age. So talk with your physician about what's appropriate. Don't forget the other cancers. That's part of being a survivor. I have to say we're all wearing pink today because we are being aware. And I appreciate that. It is a great color. But for some women, pink and pink ribbons gives them a little bit of PTSD, a little post-traumatic. They see all the ribbons and they wonder, why do I still have to worry? You know, all this research is happening. Why is it not cured yet? So I say this because it does disturb some women, so that we can all be sensitive. But we also know that by wearing pink, we are also making people aware so that we can have more survivors, get earlier detection. And for many of us who've worn pink and worn pink ribbons, it's because we're being an advocate. So we'll be sensitive for both sides of the picture here. There's some great resources out there. Cancer.net, nccn.org is where I send everybody. Living Beyond Breast Cancer Here for the Girls are a little bit more focused, particularly on the younger woman with breast cancer. So ask. You got the Sisters Network. What a great opportunity. So those are my few words, as few as I can ever say. And I thank you for your time and attention. And any questions? If I don't know where we are next for our rest of our agenda here.
Okay, thank you so much, Dr. Hackney. What a wonderful talk. It never gets old. I never get bored hearing you talk about breast cancer. I know it's near and dear to your heart. So thank you so very much.
You are welcome.
Next up, we have Dr. Vanessa Sheppard. She is the Associate Director for Community Outreach and Engagement and Health Disparities here at VCU Massey Cancer Center. She's also the Chair and Professor in the VCU Department of Health, Behavior, and Policy. Dr. Sheppard has joined VCU in September 2016 from the Department of Oncology at the Lombardi Comprehensive Cancer Center at Georgetown, where she was a tenured associate professor and assistant director of health disparities research. She has been recognized by the National Institute of Health as a disparities scholar, and her long-term career goal is to reduce inequities in cancer outcomes through scholarship, teaching, and service. She has received funding from the NIH, the American Cancer Society, and other entities to pursue this goal. She has harnessed her expertise in health services research, clinical trials, and behavioral interventions to address gaps in care for African American, African immigrant, and Latina populations. Dr. Sheppard has led studies focused on factors that have potential to improve cancer outcomes, such as treatment adherence, patient-provider relationships, obesity, and physical activity. Her team was the first to develop and test decision support and lifestyle interventions for African American and Latino women. Dr. Sheppard received her undergraduate and graduate degrees from James Madison University and Norfolk State University, respectively. She has received her doctoral degree in health services research from Old Dominion University and completed postdoctoral fellowship at Eastern Virginia Medical School and the Association of American Medical Schools, funded by the Agency for Healthcare Research and Policies. Let's give a warm welcome to Dr. Vanessa Sheppard. Thank you.
All right, so good morning, everyone. Hope you're feeling well and doing well today. I am happy to be here as a thriver, soldier, and a scientist. That means I know what to do and I can fight and I can think. So I am so thankful for the opportunity to talk to you and to collaborate with the Sisters Network and Ms. Watkins and for Dr. Cadet and this collaboration. So I am going to get started. So this morning, I'm just going to talk a little bit about some of the cancer disparities experienced by Black women. And as Dr. Hackney was speaking, I was deleting slides and moving some things around. And we'll really talk more about some of the lessons that we've learned and present some opportunities for engagement. And this is one of my favorite texts in terms of the desire that we be in good health. So one of the things that, of course, is on our agenda that we're concerned about is the low representation of minorities in clinical research. And Dr. Hackney went through several trials that are open. And what we know is when we don't have participation by diverse groups, that it lowers our ability to generalize what we find. It also limits our ability to know something specific about diverse populations. And I think that this really punctuates the need for disparities research. And so one advocate asked, if our patients are diverse in the centers that we see, really across the country, then why are our trials so white? And so we are celebrating the War on Cancer anniversary. And we know that to fight that all combatants, that means all populations, that means Black women need to have the information that's specific to their communities and to be able to fight the disease. And also we have a long way to go for the representation that we need, although it's been mandated since 1993. In terms of disparities, my focus has typically been looking at disparities across the continuum. And unfortunately, what we know is that for African American women, there are disparities across this continuum in terms of access to, utilization of, and sometimes even the outcomes of various technologies, as well as this issues related to once someone's been diagnosed with cancer and as a survivor. My research has tended to focus on the after the diagnosis component and wanting to learn to understand what can we do to make some changes. This is the only data slide that I think I'm going to really have, maybe one more. And so this is a graph that I keep with me, and as it's updated by the American Cancer Society, I like to examine, to really look at, what did we see when in the 70s. And this is at the beginning when we started to collect data really on mortality and by race. And what we see is that there was a time that it seemed as if African American women may not have had the highest mortality from breast cancer. And then as we look over time, we see changes. We see that there's a decline in terms of mortality, but we also see this widening gap. And data are most available for African American and white women. And so my perspective has always been that we know more about genetics, we know more about biology, but biology hasn't necessarily changed. Right? We just know how to name it. We know what to call, once we discovered BRCA and as such. But what has changed are new technologies to be able to identify cancer early, new treatments. And perhaps the development of these new technologies and treatments are not being equally distributed among African American women. And that's been a question that's gone in a lot of the research that we'll see today. And so the participation of African American women in breast cancer studies has been something that's been important to me because this is where my research has centered. I remember being very new in my career in the DC area and being told that being at Georgetown, I could not do work with African American women because we didn't see enough. And, I did everything I had to do in terms of working with local oncologists, whether it was tap dance, bring cookies, bring donuts, work with community partners. And you see several community partners listed below, and the survivor organizations were key. And so I'm going to highlight primarily some of the things we're learning about African American women and their treatment experiences from two studies that were large observational studies, and then talk a little bit about some other opportunities with regard to interventions. And so the first study focused on narrowing gaps in breast cancer adjuvant therapy. So the treatment primarily, after surgery, but we decided to look at surgery as well and found that similar to the literature, African American women tended to have more delays to their surgery. So about 27% of Black women had surgical delays greater than 90 days. And we chose that because that's a benchmark that if surgery occurs after that, then oftentimes the cancer may have spread to other parts of the body. And we also saw that the mean days were different. In our sort of model that we control for lots of factors, attitudes, beliefs, medical mistrust, characteristics of the provider, what we saw that there were differences between Black and white women in terms of surgical delays. But after we adjusted for trust in her oncologist, so that relationship, that the race differences diminished. And so again, we can do something about how we deliver our care in those relationships. Similarly, when we examined chemotherapy, we saw that Black women had greater delays to chemotherapy, both in terms of days and greater delay. However, once we examined what was predicting the receipt of chemotherapy, whether women had recommended treatment or not, we found that Black women who reported better communication with their providers, with their medical oncologists specifically, were more likely to have the recommended chemotherapy. The opposite was actually true for white women. And this really suggests to us that there may be different preferences when women interact with their providers. And so in fact, when we did some additional analyses, it appeared that white women tended to rely more on outside sources of information in addition to their relationships with their oncologist. But for Black women, that relationship with her provider was very important. When we talk about what we wanted to know about Black women, we oversampled Black women in this study. So this study had more Black women than white women. And it allowed us to be able to look not just at Black versus white differences, but age differences. And what we found is that younger Black women, these were women under the age of 50 or 50 and under, were less likely to have adjuvant endocrine therapy, that's hormonal therapy. And so these were women that were all HR positive or ER positive. And so it was the older women were as likely as white women to have endocrine therapy, but it was the younger Black women. And so again, sort of this need for more representation of Black women in studies so that we can parse out differences that may exist by age. One of the things I wasn't as interested in, I admit initially, was this issues related to symptoms. We collected data on symptoms, and we were surprised to see some different patterns. And so one graph shows whether or not women had very many reported high level of symptoms, and the other looks at the mean sort of toxicities or the number of symptoms. And we do see some patterns of differences by race. And our next step is to really interrogate what are these factors that predict differences in symptoms? How does treatment relate to that? How does social support relate to the reporting of symptoms? And also, we collected biospecimens. And interestingly, Black women were as likely as white women to provide biospecimens. There were no differences in race once they were in our study. And this is kind of going on its own. And so these observational data about how can we try to improve cancer care delivery has led to a trial. And this is, as Dr. Cadet knows, my baby trial in terms of a trial of the heart, where we train survivors from the community, and they're trained as interventionists. They are delivering part of the study. And we have culturally developed tools for African-American women. And this study, which is a 5-year study, is focusing on, can we improve that uptake of chemotherapy that I mentioned earlier? Can we reduce the time of initiation to therapy? And can we improve then these outcomes? And so we have several partners for this study, and the survivor coaches are critical that we're training that will be part of this study. So again, it's a longitudinal study where we will randomize one group to enhance care and the other group to our intervention. Dr. Hackney mentioned about to not smoke, and I'll say, you know, avoiding alcohol we know is also important for addressing some of the risk factors, in particular when we talk about obesity. And unfortunately, African-American women are more likely to be obese compared to their white counterparts, and less likely to engage in physical activity. And I started to have everyone stand up and move, but I know we were running behind time with our talk, so I'm not going to have us do that. But what we do have found is that physical activity improves quality of life. And so, and it's not just a vigorous physical activity, that the moderate level. And so I just like to encourage us to think about that and incorporating that into our daily life. You may have some opportunities to participate. So we did a trial in the DC area that we're offering here, and where you get to work out with a trainer, supervised exercise, learn some hands-on things related to your specific diet of improvements you can make. And this is being offered in Richmond. I'm not going to go into about genetics, but we heard a little bit about that from Dr. Hackney. And what I can tell you is that African-American women are less likely to receive a referral for genetic counseling. When they receive a referral nationally, they're less likely to show up for that appointment to get counseling. If they're counseled, they're less likely to come back for their test results. So a lot of work to do there. And we found that even among women diagnosed with breast cancer, low levels of knowledge about genetic counseling and testing. And we have collected data from Richmond area women. You can see some of the quotes here where women felt as if maybe it was their insurance status, having Medicaid, that they weren't going to be able to pay for it. Maybe that's why it wasn't recommended, or not going back, again, based on that interaction with their provider. We are launching the next phase of a trial funded by NCI for Our Health, a Black family's journey through genetic counseling and testing. And this is a trial that you can contact me and get more information about it. But this is something that was developed with Black women, for Black women in this Richmond, greater Richmond area. And so some opportunities to be engaged. You can join us in education and outreach activities. You can be engaged in our forums. And this is for everyone that's listening. You can help us set priorities for the cancer trials that we select to be a part of. You can be a participant in research by participating in a study, or by maybe being an advisor and helping us to make good choices with our studies. In the center there is Ms. Sharon Sanchez, who is engaged with us in one of our studies and helping to inform what we do. And this was a recent event that we had not too long ago in collaboration with Duke, with Dr. Winn and others. And so some selected studies you can find on our website, participation. Here, the most recent one, Women's Experiences with Hormonal Therapy. If you're interested, we're just starting to recruit, and that's focused specifically on African-American women. Just like to acknowledge, and there's more people to acknowledge that have participated in this work. There are people's names I say, Sora Brown, Sharifa McLean, Vicki Watkins. These are people who I do my research in honor of and because of. They're no longer here in this space, but they inform what I do because this is part of a ministry. This is not just a job. So disclosure real quickly, Dr. Hackney said, get your mammogram. How does one get a mammogram script in 2012 and not show up in October 14th? And she works at a cancer center. Don't do it. It can make a difference. So get that mammogram so we can be here. And mammography matters. Here's my contact information. And thank you for your time.
Thank you so very much for that wonderful talk, Dr. Sheppard. I so appreciate it, and I'm sure everyone on this Zoom does as well. I am here now to introduce Dr. Robert Winn. He's the director of VCU Massey Cancer Center. In this position, Dr. Winn oversees a cancer center designated by the National Cancer Institute that provides outstanding cancer care, conducts groundbreaking research to discover new treatments for cancer, and offers high quality education, training, and community outreach programs. In addition to directing the activities of more than 180 research members, researchers, and physicians from 36 academic departments, from 6 schools and 1 college at VCU, he also manages a research laboratory. His current basic science research, which has been supported by multiple National Institute of Health grants, focuses on the cellular pathways that drive the development and progression of lung cancer and the role of cell division arrest in lung cancer. He has authored or co-authored nearly 80 published manuscripts in peer-reviewed academic journals and has contributed 5 book chapters. Winn is committed to community-engaged research centered on eliminating health disparities. He is a principal investigator on several community-based projects funded by the NIH Precision Medicine Initiative. He also oversees the Diversity in Clinical Trials Career Development Program, a partnership with the National Medical Fellowships and Bristol Myers Squibb Foundation. It seeks to advance clinical trials diversity and improve access to quality health care in underserved patient populations in the United States while developing a more diverse medical workforce. He has received national and international acclaim for his efforts to empower underserved patient populations, improve healthcare delivery, ensure equal access to cancer care, and enroll a more diverse patient population in clinical trials. We have a very special video for you from Dr. Winn. Thank you.
I want to thank you all for the opportunity to speak to you a little bit about what it is that I do. My name is Dr. Robert Winn. I was the second ever African-American Cancer Center Director of NCI Federally Designated Cancer Center in 2019. The bottom line is I came specifically to VCU Massey, not only because of its long history since the 1970s, of doing excellent work and being designated and really trying to push the envelope of research. But I came here because I wanted to take VCU Massey to that next level of not only having science to eradicate cancer, but also to eradicate disparities wherever they exist. I'm going to spend a couple minutes with you talking about what my big overall picture is, because it's not just building the #1 cancer program for the state of Virginia. Actually, my journey, my calling, if you will, is really rooted in history. It's rooted in understanding that I know we're going through COVID right now. And I understand that many of us believe that this is the first time anything like this has happened. Remember that back in 1918, with the flu pandemic of 1918, we lost 675,000 US citizens. The interesting thing is, almost 100 years later, we've lost over 650,000 United States citizens due to a respiratory virus. That's only made even more interesting that as we are talking about these days, Breonna Taylor, George Floyd, that the worst ever racial injustice in any period of time outside of that of slavery with African Americans was during the same period as the flu pandemic of 1918. Similar to us, there was this increased racial unrest. In fact, many have termed it the 1919 Red Summer, because all across the United States, and many of you know what happened in Tulsa, Oklahoma, but you may not be aware that in Elaine, Arkansas, there were over 200 people, African Americans, killed within a 48-hour period. There was unrest and slayings in the street of people in Chicago, Philadelphia, DC, Kansas City. And so this is not new. And what I want to do for you is to understand that this cancer center that I'm running is not just based on looking to the future. It's understanding the past. Because in eradicating both cancer and in health disparities, the only way to get better is to understand and unpack the knowledge, right, of how cancer works to address it, as we have to unpack the way health disparities work so that we can address it head on. Now, I want to be the first to tell you that many of the things that we talk about today were already described in the context of health disparities by one of the social scientists greats of all time, W.E.B. Du Bois, who clearly described many of the issues that we even have to this very day in 1899 in something called the Philadelphia Papers. He described the unequal housing, the unequal policing, the unequal educations. And you might be saying to me, well, Dr. Winn, aren't you a cancer doc? Well, it turns out that we're understanding that your DNA, while it is important, it turns out that your ZNA, that is your zip code and neighborhood of association, also matter. And that the place and space in which you live has an impact on your biology. And in fact, as we start thinking about what the progress we've made since 1971 with the advent of these NCI federally designated cancer centers like the one here at VCU Massey, it's undeniable that we certainly have made some progress. We've reduced the Black-white cancer health disparities from what it was in the 1990s, which was in the 30s, now down into the teens. But I don't want anyone to get confused that we have arrived. In fact, we will have more African-American men dying from prostate cancer than their white counterparts. And certainly more African-American women dying from breast cancers than their white counterparts. Interestingly enough, while we certainly have made some progress, there's much more to make. This is an example. I use this example because I spent some time in Chicago, and it was always curious to me how the Gold Coast or Streeterville area, where residents live till 90, how if you only literally go 8.5 miles south into South Chicago, into Inglewood, the average life expectancy of those folks was 30 years different. It was 60. How does that happen in the 21st century? The more interesting thing for me is that the providers versus even the oncologists versus the patients and the caregivers are not always on the same page. In fact, when polled, this is data from the ACS and from NCCN, when polled, more than a third of actively practicing oncologists thought that their patients of color received worse medical care and communication from oncologists, from other oncologists compared to their white patients. I'll say that again, that a third of actively practicing oncologists thought that in the field of oncology, that the patients of color received worse medical care and poor communication from their other oncologist colleagues compared to white patients. I say this to say that we are now at a different point in time. And what's the big deal? What's the big deal about VCU? What's the big deal about the vision that we've actually put forward here at VCU Massey? The big deal that it's the first time that we are trying to not only break down silos, but to connect things that have been disconnected for decades. And that is that there is a disconnect between the activities of a cancer center like VCU Massey and discovering all this new stuff without connecting it to the implementation of those discoveries into our communities. Now, traditionally, academic cancer centers have, for a very long time, almost since their inception, have focused on the fundamental research and downstream factors without giving any attention to those upstream determinants of health, like housing, like food insecurity, like difficulty in transportation, which also play a role in impacting your biology. The interesting thing about this is that we will be attempting to do something big here. We are attempting to bring the science of the zip code neighborhoods of association to the forefront as much as we are going to continue to develop new drugs and actually have an impact on your DNA. We certainly believe that where you live, the place and space certainly has a biological impact. And in some cases, that biological impact tends to be much more negative for African Americans. But I want you to understand that I don't think any of this could be different unless we do things differently. And that's what we're trying to do here at VCU Massey. We're going to roll out, and we're working on it now, this equity report card. If we can measure safety in hospitals, and you can, as a citizen, private citizen, understand which groups are safe hospitals and which groups are not, and we make that publicly available. If you can understand quality about which hospitals have higher quality than the others, why are we not doing this with an equity report card? So me and folks like Karen Wingfield at Vanderbilt and others are proposing to develop an equity report card that would also be used for every health system so that it can actually have a reflection of itself. Now, the other thing that came acutely aware to me over this year and a half as a cancer center director is that, and now the truth of the matter is I love science. And if loving science is wrong, I don't want to be right. I will tell you that there is some beauty in understanding what's happening at the DNA and biological levels, which can then lead to the development of new drugs. But as we found out through COVID, you may have a new drug, but if people don't trust you, they're not taking it. This is what I term the limits of scientific miracles. And what we found was when our anchor institutions were closed, libraries, when we had the restaurants and schools and other things that were closed, that one of the things I actually recognized is that we needed to actually have community partners that were out there active. And while there was little trust, when you all recall back in March and April of 2020, while there may have been little trust of healthcare physicians, medical professionals, and scientists, there was certainly trust for people within a community like the clergy. That took humility to understand that there's only one team and one fight. And if we really want to eradicate, in this case, COVID or cancer, that we needed to make sure that we actually not only built the trust, but earned the trust of our community. Interestingly enough, there's a science in the context of building trustworthiness, which is what I don't think that many of our academic institutions or our cancer centers have ever thought about. Well, we're doing it here at VCU Massey. We are not only just as interested in your early phase clinical trials and bringing about the new miracle drugs, but we are really about the science of also understanding that we must be trustworthy before we can even build trust. In addition to that, it turns out that by working with Pastor Gray from the Fifth Street Baptist Church and Redeemed Mercer Haynes, who is just an outstanding corporate lawyer and just community person all the way, that by working with them, it has opened up my eyes into understanding that many of the times when we talk about science in our communities, that there is a wall. My goal is to bring science closer to community so that we can understand the people better, so that I can understand and target the pipettes, or that is the people, the pipette movement of making sure that my scientists are refining their scientific questions to help our community, as opposed to having questions and then coming into our communities. I want them to be able to understand that it doesn't go that way. It goes, the community informs us about what's important. I also want to let you know that we are striving to make sure that this cancer center exhibits relevance, that we're accessible even past the Zoom, and that we are flexible enough to understand that while we may have some things we need to do, that there's never a time where we can't listen and be able to work together with our community. Bottom line is, we've brought something new here, not only to Virginia, not only to the region, but to the country, of making sure that our community is not just a centerpiece at the table. Now, you know, communities can be at the table just like centerpieces. What's wrong with a centerpiece? The centerpiece is right there. It looks beautiful, but at the end of the meeting, the centerpiece is usually given away to somebody or sitting in a corner somewhere. We're not going for community seat at the table. We're going for community full-on integration. And I hope I will have your support. And with that, I will end with the fact that every Friday, if you're so interested, we have a Fact and Faith Friday that started back in March 2020. And we are absolutely certain that our facts and our faith are not at war. We bring the best experts that we can, from Fauci to the head of the NIH, Francis Collins, to internal and external experts, to not only inform our faith-based leaders, but to really get beyond even the congregations and informing the communities. I know two things that people tend not, I got this from my grandmother. She's right there, and she's just an outstanding person. And she taught me two things. One, real quick, that people don't know how much you care. They don't care about how much you care until they know that you care. VCU Massey, I am trying my best to get our doctors and our researchers to understand that when they're working with communities, that we do care. And second, that you can't do anything great without a little bit of grace and humility. And I bring that to the table in hopes that one day VCU Massey will answer the call to what I believe our communities have always wanted. And it is a great place that will not only cure cancer, but see them as people, treat them as whole, and actually understand that communities matter. So with that, I want to stop. And again, I want to thank you all for the invitation and just share a little bit with you about my thinking about VCU Massey. Thank you so much.
Thank you so very much for those awesome remarks, Dr. Winn. It was a pre-recorded video, but I will tell you all, Dr. Winn actually showed up on time as requested, but because of some delays and our start late and the technical difficulties, he was not able to come on because we switched around the schedule. So he did make his attempts, but this cancer director is just always moving, and he literally had a short span of time and he went on to another community event. So that is our terrible, terrible, terrible loss. He did say if there were specific questions that we had, that we would forward it to his office, and he will be sure to get that information back to us. He does participate in a Facts and Faith Friday event that you all are invited to. So that will be another opportunity to meet and talk to our esteemed leader. Now, I have a couple of questions in the chat from some of our participants. One of the questions are, where can we find information about clinical trials? So I will put that question to Dr. Vanessa Sheppard.
Sure. So, hello. So one of the quick ways is masseycancercenter.org. And there are a couple of places on that website. So one is through the Health Disparities Office, so the Office of Health Equity and Disparities Research. And so you can get a connection there. And then the other on Massey's website is you can actually search different trials that may be open. And there's contact information there. If you contact our office, then our community health navigators can help sort of talk through some options and maybe do a handoff with some of the clinical navigators at Massey Cancer Center more directly. But you can go to that website and spend time, putting in breast cancer and see what comes up. And also, if you want to talk to someone, if you contact our office, we can also help to make those connections about specific trials.
Thank you so much for that response, Dr. Sheppard. Another question that we received is, would my doctor automatically provide me with a 3D mammogram, or is that something I specifically have to ask for? Dr. Hackney, would you please take that question?
It's a little bit variable on that. Most doctors tend to just write mammogram, and it is not always done as a 3D. Now, many centers that do mammograms are trying to do only 3D mammograms. So I will tell you that the best thing to do is to be your own advocate there. And as long as you have a prescription that says mammogram, when you go to the mammogram center, wherever you're getting your imaging, say, I want a 3D mammogram, they should be able to accommodate you. The question they may ask you, for some insurances, it's an extra $50 to $70 to pay for it. They are trying, I know at Massey, we're trying to work at ways to get rid of that. But again, it can make a difference. So I would definitely ask.
Thank you so much for that. Dr. Sheppard, there's a question in the chat. Where can we find more of the wait times data sources that you shared? That's interesting. People usually don't ask for data questions.
I love it. I like it.
Such a terrific job. We have lay folk asking for data questions, Dr. Sheppard.
I love it. I could talk about data all day. So what I will do is I will put in, so one of the best ways is to reach me is to email me. And then we could probably set a time to talk and to go through. And so my email, I'll put it in the chat, vanessa.sheppard@vcuhealth.org. So if someone emails me, and then I will immediately loop in Mary Johnson to make sure that things get scheduled. But that's probably the best way, even better than phone, is to email me, and then I can understand specifically what's needed, and then share data that we have available. One of the things that we want to do is to make sure that our community members and constituents have access to the information that we have, so that they can understand and share within their community. So dissemination of the information is very important to us.
Wonderful. I see only one more question left, and I know we're up against time, so I'll ask that question. It's to Dr. Hackney. What percentage of breast cancer survivors get cancer again?
In terms of getting breast cancer again?
Breast cancer again, or maybe even another cancer, if that's a concern.
Okay, so from a breast cancer perspective, if you still have, there's sort of a nice couple of rules of thumb. If you still have your breast, okay, let's start with that one. You still have breast, you've had a lumpectomy and radiation. That breast that had radiation and lumpectomy has less than a 5% chance of getting cancer in it again over the next 20 years. The opposite breast, exposed to the same stuff, but not radiation, has about a 1% risk of getting breast cancer over the next 10 years. So it's not a hop over. It is a whole new cancer developing in the opposite breast, about 10% over 10 years, okay? The risk of getting cancer elsewhere in your body depends on what type of breast cancer you had. So that can be as low as 1% or as high as 50%, depending on your cancer. For other cancers, you're at, without a genetic history, you're at the same risk everybody else is. So, you know, if you're over 55, unlikely to get cervical cancer, but colon cancer is one of the most underscreened cancers we have. So get your colonoscopy. And again, endometrial cancer, if you have bleeding and you're over 55, and you know you're not having a period, get it checked out. Don't sit at home.
Thank you
And-
so much for that.
Dr. Hackney, too, I guess just to kind of circle back to the points that you were making earlier and about adherence. And so, you know, some those statistics in terms of recurrence and development of new cancer is also assuming that people have had the full course of treatment. And so I just want to underscore that completing, you know, the chemotherapy, completing
Right.
all your radiation, you know, having and staying on your adjuvant endocrine therapy. Right, for the minimum 5-year course. So just want to underscore that it's not surgery and done. It really is, you know, the better outcomes are when people complete their treatment.
And to that point, Dr. Sheppard and I are both involved in some trials of trying to get that compliance improved because